Okay, so this is my first case. This is a middle-aged woman who got an MRI for some abdominal pain. And I'll just point out the finding is here in the pancreatic tail. So this is the finding here, and you can see that there's also a cyst within this lesion. That's the T2. Here's the pre-contrast, which is really nice. You can see that it's definitely a lesion. It looks different than the bright pancreas. It's kind of darker. Here it is on the arterial phase, so it's sort of hypo-enhancing. Venous phase, it's kind of iso-intense. Any thoughts?
How old is the patient, Aarti?
Middle-aged, like 50.
I was wondering whether it looks like a solid, like a SPEN. I know it's a wrong age group, but.
Good thought. So yeah, SPENs when they're smaller can be solid looking and enhancing. And this one actually was like kind of restricting diffusion.
You know, neuroendocrine tumors come in various flavors. I've seen different appearances.
Mm-hmm.
So
yeah, and they say about 10% of neuroendocrine tumors are hypo-enhancing, so it doesn't have to be that avid arterial enhancement.
Right.
We also were contemplating a splenule. Do you see here, it's kind of restricting similar to the spleen, and it was actually following the spleen on multiple sequences.
On the first sequence, it didn't look like the spleen, the first one that you showed, I thought.
This one, yeah, it looks a little darker than the spleen. So we brought up, you know, could this be a neuroendocrine tumor? It looked a little too rounded to be a adeno, but it was hypoenhancing. So we said adeno, neuroendocrine tumor, and possibly a splenule. Would you guys recommend a biopsy or a nuclear medicine scan?
EUS and sampling.
Nuclear medicine.
Nuclear medicine. So we were debating back and forth. And normally, if I'm really leaning towards splenule, I'll recommend the nuclear medicine scan, like a sulfur colloid scan. This case, we really weren't sure, and multiple people were concerned it was something else, not a splenule. So they went for a biopsy, and I'm not going to tell you what it is. I'm going to give you another clue. It was not an adenocarcinoma or a neuroendocrine tumor, and it was not a splenule. And this is the clue. So this is for whoever remembers their neuroimaging.
Oh gosh, is the cella empty? There's
a tumor.
Yes, so there is thickening over here and a little bit also on this side. And it's actually separate from the muscles.
The IgG4 disease.
Yeah, so this was IgG4 autoimmune pancreatitis. I'd never seen, I mean, I know you could get them focally, but it was just like a kind of a surprise. None of the other organs in the abdomen were affected. We didn't see anything in the kidneys, the retroperitoneum, so kind of wasn't even on my radar. And I didn't look back in the chart to see that actually this patient had been having a lot of issues with their lacrimal gland and swelling. This had been going on for months, and they had brought up several different things, including lymphoma, sarcoid, and IgG4. So anyway, this, it turns out IgG4 orbital disease, the lacrimal gland is actually the most common area to be affected. You can also get it affecting your orbital muscles and then other parts of the eye. So anyway, and this patient, their serum IgG4 also was over 400. So it clinched the diagnosis, but on biopsy, this pancreas also came back IgG4. So this was systemic IgG4 with focal autoimmune pancreatitis in the pancreas and also lacrimal gland involvement. Okay, and they're undergoing steroid therapy. Okay, this is my next case. This patient had had a renal transplant a year ago and over a year ago. And then about a year ago, they had rejection and it was very painful and they removed the renal transplant. And then this is what is the appearance of the right lower quadrant 1 year after they removed the renal transplant.
Can this be PTLD?
Great, good thought. So we also thought, they're immunosuppressed. There's this big mass-like structure down here. So PTLD was raised. Another thing that was raised was, could this be an abscess or some kind of hematoma? We can see that there's some surgical clips from the explant, from taking out the kidney. There's even, you can see the ureter going kind of towards the bladder from the kidney. So anyway, they biopsied this and it came back basically fibrous material and inflammatory cells. We then did an MRI, and this is what the MRI looked like. So you can see that the process is T2 bright. And actually the caudal part of it looked almost like part of the kidney and part of the ureter as well, going towards the bladder here. And when we talked to the surgeons, they said when they went in to take out the original renal transplant, it was very inflamed. So they probably left the lower pole behind because there was a lot of inflammatory stuff. But there's also all of this stuff that's T2 bright. And then actually post-contrast, this is what it looked like. So it was definitely not a fluid collection. It looks like it was T2 bright, but also really, really enhancing soft tissue here. So I was concerned maybe this was like a sarcoma, lymphoma, like PTLD, like we were talking about, although they have not been on immunosuppression for a year. Maybe Steve is saying inflammatory pseudomass. Good, excellent. So this was again biopsied. We did large core biopsies of this, and this actually came back IgG4. So this was the kind of most surprising case of IgG4 that I've seen. They had, greater than 80 IgG4 cells per high-powered field with all of the classic kind of pathologic features here. So for some reason, this remnant portion of the renal transplant induced this inflammatory response that ended up inducing this IgG4 kind of pseudomass. Anu saying, wow, Steve says, wow, yeah, really surprised us. I was convinced this was going to be like either a sarcoma, or I thought maybe a renal cell carcinoma from the remnant transplant, although this would have been really rapid development because they don't usually grow this quickly in 1 year. Okay, this is my next case. So the process is in the liver. Focus on, we've got this, these like T2 hyperintense serpiginous structures. This one that looks almost like it has something in it. This is kind of what it looked like on the coronal.
It looks like there are dilated ducts distal to this process as well, right?
Yeah.
Not
so
only upstream, but downstream as well.
Mm-hmm. Yeah, so there may be some soft tissue here, but then there's dilated ducts and ducts.
I'm thinking something like IPNB.
Yes, good. So this was resected. The patient ended up getting we called this concerning for IPNB. We thought that this was like the papillary frond kind of aspect in the, and you can see here, it's like enhancing within there. The rest of it is kind of dilated bile ducts. And then it's not really like the mass was obstructing, like you can still follow the bile ducts and they're still dilated proximal and distal to this soft tissue part. Anyway, they ended up getting a right hepatectomy, and this was all IPNB. They said the IPNB was about 3 centimeters and the right bile duct margin was positive for dysplasia. There was a lot of low-grade dysplasia, some areas of high-grade dysplasia, and then several 3-millimeter foci of adenocarcinoma. So it's kind of a classic IPNB picture where it's got like, you've got dilated bile ducts, papillary stuff, but a lot of this was just actually dysplasia. And even like there's dysplasia along the wall of the bile duct here that we can't really see. And the margin was positive, but it wasn't positive for adenocarcinoma, just for dysplasia.
Aarti, can I share something?
Yeah.
I'm still waiting to prospectively diagnose my first IPNB. I've seen them in such beautiful illustrations like this one, but I'm waiting
Well,
for that
I mean,
day.
you would have prospectively gotten this one.
Yeah, I guess so. It's just that I haven't come across a case yet. But this is a beautiful case, yeah.
Yeah. That's why I wanted to show it. But I think Millie showed one like last week or the week before. So I think people are probably going to get sick of seeing IPNBs. But I'm starting to think they're more common than, just something super rare, because everyone in this conference is starting to bring one. So Steve says he might have just seen his first. He's awaiting path. Cool. You'll have to bring it here. Okay. And then this is my last one. This patient was having pelvic pain. And this was one ovary. We can see multiple follicles. This was another ovary. There was this structure here. It's a little T2 intermediate to dark. This kind of gives it away. This is the pre-contrast.
Like an endometrioma.
Endometrioma.
Yeah. So, and this is a nice example where we've got multiple endometriomas. So the really, really T1 bright structures we see in the left ovary, and then this huge endometrioma coming from the right ovary. Might even be part of the tube, actually. This is probably part of the tube, but then this might be a part of it as well. There's like this little septa here. So multiple foci of endometriosis with shading. So it's really T1 bright, and then relatively darker on T2, although it's not super dark here, but all of those little lesions were T2 darker. And then they also have this, so you can see that there's this band-like fibrosis that is tethering both of the ovaries together, kind of like the kissing ovaries, but and it's also tethering the rectum here. So we've got deep invasive endometriosis as well as those endometriomas. Just kind of a nice example.
Okay, so this is a pretty old case. Hopefully you can see it's not hard to see the finding. This is the original presentation, I think. And I'm not looking at the chat if anybody's saying anything there.
Like a retroperitoneal liposarcoma.
Yeah, well, that's the thought. It's kind of circumscribed, but it looks so busy, and it's not clearly of the right kidney, in which case it might be something different, right?
One of the chat responses is it an exophytic AML?
Yeah, so that was the differential. Are we looking at an exophytic AML, or is it a liposarc? Because it's so circumscribed, maybe it's AML, and maybe this is hemorrhage, which they can bleed when they get big. And then, but you'd kind of like to see a spot from the right kidney where it seems to be coming from. Anyway, they did percutaneous biopsy. The biopsy was difficult to interpret, I guess. Let me just make sure that this has no PHI. So this is 2 months later. It looked like this, with basically hadn't grown very much. Some of that stuff here, which has attenuation value of around 25, 30, was a little bit smaller. So maybe that's supportive of AML, but the overall size was the same. And the biopsy was kind of inconclusive, leaning towards AML. And they did take it out eventually. So the patient ended up with right nephrectomy and a mass removal, and it was an AML the whole time. So this is one of the more scary looking AMLs that I've seen. And I've seen some myelolipomas that look hard to differentiate from a retroperitoneal sarcoma. This is probably one of the AMLs that I had the hardest time differentiating from a retroperitoneal sarcoma.
It's very interesting because there's no claw sign, or like you said,
Yes.
there's no clue that it might be coming from that kidney.
Yeah,
Right?
I know. Yeah, they didn't really comment on it on the path. Like when I read closely the path report, they just basically say it's an AML, and they don't really say like where of the right kidney it seems to have origin from.
Mm-hmm. Wow, nice case. Thank you for sharing.
You're welcome. That was just one of my recent follow-ups that I looked over. I don't know if anybody else has something. Looks like Aarti's given up on us. Oh, she's still trying.
All right, I had a question for the group. If you are scanning a patient who comes for the first time with a question of an FNH or an adenoma, would you start off with an Eovist, or would you start off with dotarum or an extracellular contrast agent?
So for you to know that there is an FNH or an adenoma, they would have had some sort of scan previously, right?
Right, maybe a CT.
Yeah. In that case, I would go ahead with Eovist.
Me
Because
too.
here it's more of a characterization question.
Right, so a recent article just said that beta-catenin as well as inflammatory adenomas take up Eovist.
Right. There is a small percentage though, isn't it? Did they specify what is the percentage of them?
I don't know the percentage, but then having said that, does Eovist really help that much?
Yeah.
I think it does. I'm back, sorry. I think that if it has the very classic features on all the other phases and then retains on the Eovist, I would feel confident calling it an FNH. And like Anu was saying, it's this smaller percentage of inflammatory adenomas, although we need to be more and more cautious about them. But I've seen some papers that say that when they do retain, they're more heterogeneous. They might have more fat, although FNHs, just to be warned, can have some microscopic fat. So I think like I take all the features together, the Eovist can help me feel like more confident or say like, oh, this looks atypical. It could be in this inflammatory adenoma range.
Yeah, but because now there is a paper which says that beta-catenin also takes it. So you have two of the 4 types that take up Eovist. So that was.
And you also have HCCs that do it, but at some point we have to give a little bit more help than, FNHs are still quite common. So I think if it looked like FNH on every other sequence, I would still say, I think this is FNH. I don't think you're basically saying, should we like Eovist is no longer reliable?
Is it really that helpful in these cases? Yeah, basically.
Kedar, does the paper tell us what next, if not Eovist?
So I don't remember. Gitanjali, do you remember the?
No, I think they don't say that we should or we should not be giving Eovist. All they said is like that this is this new radiographics article which talks about Eovist and its applications, and they say that now beta-catenin is the one that I think 20% of them show Eovist uptake. So then after that, it just leaves you in like nowhere. Like then if you see uptake in a lesion, then what do you think of, whether it's more of an adenoma and FNH? But at the same time, I have this question for the group, and I would like to know what their experience is, because I personally feel that the uptake of an FNH or a retention of Eovist by FNH is somewhat different from other lesions like adenoma and HCC. So thinking of their pathology, FNH is more just hypertrophied hepatocytes, right? So it's more uniform uptake of Eovist, except that central area of scar. And it has those, and as Aarti said and Anu said, we have to take other features in account too. They usually have this feathery lobular outer margin, whereas adenomas are more discrete lesions, and their Eovist uptake, even if it's there, it's little. First of all, only 20 to 30% of the adenomas will retain Eovist. And even if they show Eovist retention, it's very little. It's not as much as an FNH will show. And FNH will looks more feathery on Eovist images. But
in all honesty, I've seen different patterns of retention of Eovist in FNHs, meaning just peripheral, cloud-like, different kinds of patterns of retention. And then one thing is, I look at the T2, and if it's a stealth lesion, I favor FNH over adenoma, because I always feel T2 is brighter in adenomas. I don't know if you folks have a similar experience.
I agree with that. I agree with that 100%. But that's what I'm saying. So when you have the other features and we are using them so much, is Eovist really helping as much?
I don't think it's helping as much as we thought it was when we first started using it. But I agree that, if you're going to do the MRI with contrast anyway, I think there's a little advantage to using the Eovist, and there's no substantial advantage to or disadvantage to not using it. It's potentially helpful.
I agree. But I think this is a great, maybe we should have like a little journal club next time on FNH versus adenoma or something. And like look at these papers and the examples they're showing to see if like what we're saying is true,
Yeah, I think that's a good idea.
Let's do that. Great idea.
Yeah, I think this is something that we encounter every day. Like these cases are plenty, and there's always a question, like a discussion on what is it. But for T2, what I like to add is, because I've read recently a lot on these, and the T2 bright signal is probably more with inflammatory adenomas. And the one that are, they have more fat in them and they're seen in fatty livers, they look T2 dark. So the T2 signal is variable in adenomas. But yeah, if it's a stealth, like totally iso to the liver, that's where FNHs, I think, are more likely.
And just to add on to that, I recently had a case where there was extensive fatty infiltration, like steatosis of the liver. And so even after giving Eovist, you couldn't even figure out that because the liver didn't take up any or didn't excrete any Eovist. And so you couldn't even make out it was an Eovist scan. And then the lesion remained bright. So, I mean, I still struggled, and there were multiple of them. So still struggled whether to call it adenoma versus FNH. And I can show that case next time just to get everybody's opinion.
Yeah, I think when you have like a severely fatty liver, it gets really tricky because all bets are off. Like you can't really compare it to the background liver. It's kind of like a mind trick, but that would be great to see the case. Cool. Anyone else have cases or questions?
I have one quick case, Aarti, but I have a partial follow-up on it. I don't have a biopsy proven follow-up. Yeah. I hope you all can see my screen now.
Yes.
So this is a young female who has history of pelvic abdominal pain going on for maybe 1 to 2 years. And now she had this severe pelvic and lower abdominal pain associated with nausea, vomiting, diarrhea. So that's the CT. So my question was, how will we read this and what would be your main concern? We're focusing on the pelvis findings.
There's obviously some inflammation going on at the sigmoid colon. It's a little bit long for diverticulitis. Plus, I'm trying to find some diverticula, which there don't seem to be too many.
And she's only she's 36 years old. That's really. Yeah.
I mean, I've seen some diverticulitis in 30-somethings, more males than females, probably on average.
So yeah, that's what was called on this case, that this is probably colonic inflammation, colitis. And so they did a colonoscopy after 3 to 4 days once like so much of acute inflammation subsided, and the colon was absolutely normal, no abnormality with the colon. So they got the MR done they ordered an MR enterography. That's why the pelvic findings are not in the center of the field, but this is what the MR showed. This is the axial haste. This is the post-contrast.
Do you have a pre-T1 through the pelvis?
Yeah.
The right ovary is posterior, stuck to the back of the uterus.
Yeah, and it has a
Yeah, T1 bright.
T1 bright or enhancing lesion.
Yeah, this is the pre-contrast
T1
T1.
bright.
Yeah.
Endometriosis.
Yeah. I was thinking the same.
Yeah, so I think, so that, yeah, for sure, I think she has pelvic endometriosis. As I said, I don't have a complete follow-up on this. So the only thing on this one is, I think it's more of some pelvic inflammation that's causing this reactive thickening of the colon. And that's why when they did colonoscopy, the colon was normal. But what we would, the question was then what is it that that can explain all that inflammation in the pelvis? Because I've never seen so much of fat getting inflamed with just endometriosis, or maybe that she had superimposed PID. So we've recommended a GYN evaluation for her, but that's the follow-up that I don't have. But yes, she does have pelvic endometriosis and something to do with like a GYN etiology for this colonic thickening, and this was not colitis.
Do you know if
Almost
her it
Sure.
lines up with her recent menstrual period? Like I wonder if that endometrioma got inflamed or like burst a little bit and then inflamed that colon. But I agree, I've never seen a colitis like that from a nearby endometrioma. More like bowel obstructions or tethering.
Yeah, but never such inflammation. Yeah, no, we didn't. I'm not aware of her menstrual history. So yeah, don't have that information. I think I can show one more quick case. Okay, another Crohn's case. Young female who presented with probably, I don't know the history, maybe some like sudden onset severe abdominal pelvic pain.
It's almost like looks like she has a fistula between her thickened sigmoid colon and her left ovarian cyst.
Yeah, I think that's what we questioned. I think this is where the scarring is, and it's probably the bowel is inflamed and it's creating a fistula with the left ovary. So yeah, I mean, that's what, I mean, I don't know how to get a definite follow-up on this, but since this was obviously looking ugly, had air and fluid in it, they did an guided drain and she was a little better. They did a follow-up MR on her, which showed that this became a little smaller. You can see the edematous ovary in the periphery. Let me bring up a T2. And this was just air left at that site of abscess. So my question was, is it frequent to have fistulization to the ovary? Because I think what I remember from reading earlier that ovaries are pretty resistant to infection, and I know they can get involved with tubo-ovarian abscesses too, but is this something that is commonly seen or?
I would say not. Like even if you have severe, we've seen cases with severe IBD, which here looks like you have multifocal like loops that are involved, but I would say most of the time we see fistula between small bowel loops, between small bowel and colon, maybe to the skin, but I've not seen as many to the ovary, although actually I've seen more where appendicitis is secondarily inflaming the ovary, but not necessarily fistulizing.
Fistulizing from Crohn's, yeah, that's what I thought that. So maybe then I can show this case too, which is somewhat unusual for Crohn's. This is a 60+ lady who again had a lot of bowel changes from Crohn's in the pelvis. And the question was this fluid collection in the pelvis. I think she had CKD too, so all these images are without contrast.
Is it a huge like pseudosacculation?
Yeah, so again, I don't have a definite follow-up on like what this turned out to be. My question was, how will we read this out and what differentials can we give for this fluid collection? It's hard to follow, but so this is so they've had prior resection and anastomosis. So this is the site of anastomosis, and right This is probably the neoterminal ileum, which is thickened and inflamed. And then there's something here that connects to the cystic structure. That's actually the uterus. So this is the cervix. That's the fundus of the uterus.
Is it a dilated tube? I'm thinking.
That's what I'm thinking. Was it involving the right adnexa? Because so this is the, I don't know if you all can get convinced that this is the cervix. The uterus is small, but everything is scarred to the fundus of the uterus. I thought there was evidence of like an ovarian tissue here.
Can it be a peritoneal inclusion, Gitanjali?
That was the other thought, but the only thing is in like she's 60 something. So do we get like the peritoneal inclusions is the theory is like it's the ovulation fluid that gets accumulated and it's not able to get resorbed by the peritoneum because peritoneum has adhesions from Crohn's. So I don't know if that can happen in a, but yeah, that was other different consideration was whether this is an inclusion cyst. The other thing is these are two follow-up scans. This one, these two scans are 3 months apart and nothing has changed. It stayed stable. So they were asking whether they should like drain this or not.
Yeah, I think that's the important. I think that's the important point here is that it doesn't really look like an abscess, right?
Yeah, yeah.
So whatever we call it, it's some kind of either outpouching, giant diverticulum, pseudosacculation, whatever, but it's not, it doesn't to me look like acutely inflamed. I don't think it needs a drain, but it does look like that stretch of colon next to it has like a long, almost inflammatory stricture with upstream dilation and things like that. And so that needs some anti-inflammatory medication, and if it doesn't resolve and becomes fibrotic, then they could need surgery again there.
Yeah, I think one of the considerations was whether they should just resect this whole thing out, but I think she's already had a lot of bowel resections in the past, and the only worry with additional resection was she'll be left with a very small bowel, like having a short gut syndrome from it. So that was the question on this case. Yeah, but like the question was like, can elderly females have peritoneal inclusion cyst? Is there any? I couldn't find any papers on it.
I think it's much less common because it's usually the menstrual, like the
it's usually related
fluid.
to cycle. Yeah. So once the cycle stops, I don't know, ovaries can still produce fluid and can get accumulated. It could just be reactive fluid which got loculated in the peritoneal cavity.
Yeah.
Yeah, just some like varied manifestations of Crohn's disease involving the adnexa. I think that's all I had.
Nice. Those were nice MREs. Okay, anyone else? Okay, see you next time. Bye.
Thank you.
Thank you.
Thanks all. Bye.